This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on AFib, or atrial fibrillation. And today we have a special guest. We have Dr. Richard Vest, who's board certified in electrophysiology and is the director of the electrophysiology lab at St. Vincent Hospital here in Birmingham, Alabama. So Richard, welcome to our podcast, and we have a lot to talk about, today, because AFib, of course, is a huge problem and it's growing fast. It's estimated that over 3 million patients have AFib just here in the US, and that over the next 30 years, that number will reach about 12 million. It comprises over 5% of the population over 65 and 10% of the population over 75 years of age. And that's not all. There's also this so-called subclinical AFib. Reports have been mentioned in the literature of silent AFib. That means episodes of atrial fibrillation where the patient was completely unaware, in approximately 20 to 50% of the patients with either dual pacemaker or dual ICD devices. So there's a huge potential of underdiagnosed AFib. If we know also that AFib has increased morbidity and mortality, there's an increase of 5 times the risk of stroke with AFib, 3 times increased risk of congestive heart failure, and double the risk of dementia and mortality. So, Richard, we have a lot to talk about, but let's start from the beginning. If you could explain to us what is AFib and how does it compare to a normal sinus rhythm?
Well, thanks so much, Dr. Bouchard. It's great to be with you on this discussion, and this is a very important topic, and it's my pleasure to be able to discuss it with you. Atrial fibrillation describes an abnormal heart rhythm, and of course, we know that the heart has an electrical system, and so there's 2 upper chambers, the atria, and 2 lower chambers, and every time the heart beats in a normal rhythm, one electrical impulse starts at the top of the heart, and it goes through the upper 2 chambers and then down to the 2 lower chambers, and it causes the heart to be activated. But when atrial fibrillation happens, electrical impulses are very chaotic in the upper 2 chambers. So electrically, it's a little bit like a sandstorm. And fibrillation means quivering. So there's a quivering of the muscle in the upper 2 chambers, or a continual electrical activation. It's a little bit like just constant muscle activation. So the upper 2 chambers are constantly being activated, but as a result, there's really not good contraction of the upper 2 chambers. There's just a quivering. So it's somewhat of a mechanical standstill. And then the bottom 2 chambers end up being irregular in the activation pattern. So it's described as an irregular heart rhythm. And in most patients, the heartbeat tends to be very fast. So that is by definition atrial fibrillation, although it can be a fast heart rhythm or a slow heart rhythm or everywhere in between. It is typically irregular.
Great. A lot of my patients ask, what causes AFib? I mean, why is this happening to me?
Absolutely. So atrial fibrillation is associated with a number of different things. And the fact is, you already mentioned that it's become an epidemic in the developed world, especially in the United States. In 1996, there were 2.3 million adults that had atrial fibrillation. And you just mentioned the statistic, and that is we're already up to nearly 5 million and we're expected to be towards 12 million. So it's a logarithmic expansion of AFib. And we would think that is associated with the risk factors and things that specifically cause it. So probably the number one of all of those is hypertension. Elevated blood pressure can lead to increased pressures on the inside of the heart. And when those pressures increase, it leads to enlargement of the upper chambers of the heart. And when there's enlargement of those upper chambers, that can lead to this electrical abnormality, atrial fibrillation. But it's not just hypertension. Coronary artery disease is an association, diabetes mellitus. And then there's additional things: sleep apnea, obesity, excessive alcohol use. All of those are things that are associated, and potentially those are modifiable risk factors for atrial fibrillation.
So it seems like all these risk factors may be related to some enlargement of that chamber in the back of the heart, the left atrium, and possibly some fibrosis, that gets involved there, and or sometimes some inflammation that can develop there.
Correct. So I think about it two ways. So from one perspective, there can be dilation or enlargement of the upper chambers, the right atrium and the left atrium. But in addition, there can be higher pressures. So even if there's not enlargement, if there is something that is happening physiologically that increases the pressure in the right atrium or the left atrium, then it leads to inflammation of the inside of those chambers, and that can cause irritation. So anything that increases the pressure or anything that causes dilation of the upper chambers can lead to AFib. And the way I describe it to a lot of patients is, imagine being in the sun, and imagine having skin that's very healthy, and if there's skin that gets sunburned, well, perhaps one or two sunburns doesn't bother the skin that much. But if one's skin gets sunburned day after day after day after day, then it will lead to some chronic changes in the skin, some fibrosis or some inflammation. And the exact same thing can happen on the inside of the heart in patients who have a clinical syndrome that either causes enlargement of the atria or increased pressure of the atria.
That's great. So if you have AFib, what kind of symptoms should the patient expect? I mean, and actually, can you really tell whether I'm truly in AFib or not? If my heart is, feeling some palpitation, how good are the symptoms in predicting, whether I'm in AFib or not?
It's completely variable. And so there are some patients who the most classic description of atrial fibrillation is someone who says, I feel my heart beating rapid and I feel it beating irregularly. It feels like butterflies in my chest and my heart is just racing. And some people have described it almost as a Morse code in their chest. And so that is a very classic description. And when someone describes that to me, then I'm very concerned that the patient may have atrial fibrillation. However, the symptoms are tremendously variable. So I would say the majority of patients who come see me for AFib don't have the classic symptoms that I just described. Many of them have other symptoms, and it can range from a patient having shortness of breath and dizziness, or I've had patients who have had significant fatigue, or patients who have had chest tightness or even some chest pain in the setting of their heart racing. So I think the symptoms are variable, and my encouragement to patients is when someone feels symptoms or feels any sort of irregularities in their chest or in their heartbeat, it's important to seek medical care to try to get a diagnosis.
Sounds great. I mean, and I guess you have some of my patients, particularly elderly, women that don't feel anything at all. I mean, they have no symptoms, and it's just, detect on the regular routine electrocardiogram or someone just checking their pulse. So that leads into, how do you make a diagnosis of AFib, Richard, and what is your kind of, regular workup for a patient with AFib?
Absolutely. And I want to, you just mentioned something that's really important. And that is that a lot of patients will come in and report that they're not having any symptoms at all. And I'm sure we'll be talking about that in a little bit here. But one of the reasons that that's important is because symptoms often drive what we decide to do for our patients. However, as physicians, it's really, really important that we do a very good job in talking to patients about the symptoms that they're having, because many patients will have atrial fibrillation and come to the doctor. And when it's found, they will say, I don't have any symptoms of my AFib. I don't know that I'm in AFib. But it's important for us as physicians to really probe into that a little bit more and talk to the patient. So as I mentioned before, a lot of patients don't have those palpitations necessarily, but when you start talking to them and their spouse is with them, then the spouse will say, oh, my husband, he hasn't felt like going and exercising for 4 months now. He's just been kind of a little short of breath, and he's been very fatigued. And then when we start probing into it, we say, well, the patient isn't having palpitations, but their symptoms are fatigue and shortness of breath, and those symptoms have been going on for 4 months. So even though the patient says, I'm not having any symptoms from my AFib, they just don't understand that their symptoms are actually shortness of breath and fatigue. And so it's very important for us to be aggressive in treating their atrial fibrillation to address the shortness of breath and fatigue. So when a patient has atrial fibrillation or is suspected of atrial fibrillation, the gold standard for diagnosis is an electrocardiogram or an EKG. The challenge in diagnosing AFib, however, is that a patient can flip back and forth from sinus rhythm to AFib. And so some patients are in AFib continually, but some patients are in AFib only 1% of the time. And that can present a real diagnostic challenge, because if a patient is in normal rhythm 99% of the time, but in AFib 1% of the time, then it means that when they go to the doctor, they've only got a 1% likelihood of catching their AFib when they come see their physician. So that leads to a number of options for us to make a diagnosis. If the patient is in AFib in the doctor's office, we can perform an EKG right there where we put sticky pads and wiring on the chest and run an EKG and make a diagnosis right there of AFib. But if the patient's not in AFib, then we can check a cardiac monitor. And a cardiac monitor is a small device that is about half the size of the palm of my hand. It has adhesive and it sticks on to the patient's chest, typically on the left upper side of the patient's chest. And it's something that a patient can wear 24 hours a day for as long as we feel is appropriate. And sometimes I'll have a patient wear a cardiac monitor for 24 hours, and we have the potential to do it for up to 1 month if it's needed. And that way, if a patient is having episodes of AFib that perhaps may only last a few minutes, then that heart monitor will be able to record those episodes, and then we can download the data from that monitor and get a full report. So that can address that situation. And then we actually have even more extended heart monitors called implantable loop monitors. And those are actually very small devices that are about half as wide and half as thick as my pinky finger. We make a little incision, 1/4 of an inch on the upper left chest. We just use some numbing medication and don't have to use other anesthesia. And we can put that little implantable loop monitor underneath the skin. And it actually records the heart for up to 3 years. And so it's a really, really great diagnostic opportunity for patients who maybe would only have symptoms of palpitations or other symptoms, perhaps once every 2 months or every 3 months or whatever. And so for those patients, it's a really great opportunity to make a diagnosis of whatever abnormal heart rhythm that they might be having, if the wearable heart monitor is not yielding in wearing it over a period of a few weeks.
So if the patient is having a lot of symptoms, I mean, it's like very, very frequent, a 24-hour Holter monitor is perfect. But if you have symptoms that are not so frequent, it just kind of happens just a few times a week, it looks like an event monitor that a patient could, wear for 2 weeks, 2 to 4 weeks should be sufficient. And I guess if they're kind of rare, just a few times a month maybe, or just every few months or so, like you mentioned, and then maybe the loop recorder. And it's just something you put under the skin. I mean, it's something that almost could be done as an outpatient, couldn't it?
Correct. That's exactly right. It can be. The other advantage of that is, because the symptoms of atrial fibrillation are so variable, and because atrial fibrillation can be continual, but it also can just be less than 1% of the time. One of the ways that sometimes atrial fibrillation gets diagnosed is after a patient has a stroke. And of course, that's always an unfortunate situation because we want to make that diagnosis before an adverse event like a stroke happens. But if a patient has had a stroke, perhaps we're concerned, even if they're in normal rhythm when they have their stroke, that they've been having episodes of AFib before they presented with the stroke. And so the implantable loop monitor is a great option for that patient because going forward, if they have episodes of AFib, we want to make a diagnosis so we can provide therapies that would prevent perhaps another stroke that could happen in the future.
Now, there are some other devices, so-called portable devices, like a few years ago, they came up with this Kardia, K-A-R-D-I-A. And now you have the Apple Watch, with the where you can kind of monitor the heartbeat and even have a recording emailed to the doctor's office. How accurate or how good are these devices?
I think they're actually very good. So the advantage of these devices is that they work very well for patients who have symptoms. So if a patient is having symptoms and we're not sure what is going on, then if the patient pulls out the Kardia device, let me back up a little bit. So the Kardia device is a small flat device that a patient can buy. It hooks into the smartphone through Bluetooth, and they can keep it in their pocket or their purse, or as long as they keep it handy. Then when they're having their symptoms, they pull it out, pull up their phone, and it makes a tracing. And then the Apple Watch is a similar thing. Both of them are essentially a one lead EKG. So it essentially takes skin contact from one hand to the other, and it's the equivalent as though we did 2 wires with 2 stickers on the patient's arms in the office. So it creates a tracing that's actually very, very good. And I've had a number of patients who've brought me their tracings, and I've looked at them, and I've felt that the quality was excellent, and we did not even need to do a cardiac monitor in those situations. However, the one caveat about those devices is that the patient has to do a tracing. And so if we're not really sure what the patient's symptoms are, if we're not sure how often they're happening or things of that nature, there's no continual recording. It's only a recording that is done when a patient is having symptoms or when they actually do the tracing themselves. So it's not 24-hour a day, 7-day a week recording as those other devices that we talked about. But for a patient who's having symptoms, it can be very, very helpful.
That's an important point. Plus, we know that, in patients that have symptoms of AFib, if you do a continuous monitoring of them, they have probably twice as many episodes of AFib without them even knowing about it, right?
That's absolutely correct. Even patients, and again, there are some patients who genuinely have 0 symptoms. So, but those patients are the minority. It is by far the vast minority of patients who truly have 0 symptoms of their atrial fibrillation, even the ones who are initially convinced that they have 0 symptoms of their atrial fibrillation. But for patients, even those who say, "Oh, I know when I'm AFib, when I'm in AFib, I'm confident, here's my symptoms," we do a heart monitor. And sometimes I'll say, "Did you know that you were in atrial fibrillation on this particular day at this particular time?" And they said, "No, I wasn't." And I'll pull out the tracing. I'm like, well, look, here's the recording. Here it is. And so it's surprising. They're typically having a lot more episodes of AFib than they actually think they are.
Yeah, we're getting a lot of information, particularly in patients wearing pacemakers and ICDs, where we're discovering so much AFib. This subclinical AFib that is in incredible proportion, where we really truly don't know exactly what is the consequence of all these silent AFib. But
Sure.
obviously, let's talk about treatment a little bit. So we have someone in AFib. I mean, there is this well-known triad, and obviously we want to prevent a stroke. Number one, we don't want the rate of the AFib to go too fast. So rate control is important. And then there's sometimes we want to do this rhythm control. We want to get them out of AFib and get them in a normal sinus rhythm. So we got a lot to talk about, and this is a lot on our plate, Richard. Let's start first with the stroke prevention, first of our triad. How do we do that?
Absolutely. So that and I'm glad you brought that up first, because that is the most important thing I think to think about is when a patient's having atrial fibrillation, first address the risk of stroke. And of course, the reason why the risk of stroke is increased is because we talked about how there's that fibrillation of the right atrium and the left atrium, or the quivering. So as a result, the upper chambers of the heart are not squeezing blood in the way they normally would. So that results in stasis of the blood, or a pooling effect, a little bit like an eddy in the river where the water is not very clean and it's not flowing. So it creates a perfect setup for clots to form in the upper chambers of the heart. After clots form, they can dislodge and then go to the brain and cause a stroke, or they can go to other areas of the body as well and cause other problems. But the biggest problem is when a stroke happens. And the risk of stroke is not the same in all patients. So some patients, based on their clinical factors, have a much higher risk of stroke compared to other patients. So there's a risk score called the CHADS-VASc risk score. And it's basically a mnemonic that is based on a number of different clinical factors of atrial fibrillation. So the higher the risk score in patients, the higher the risk of stroke. And the lowest score is 0, the highest score is 9. And it includes risk factors of age greater than 65, age greater than 75 counts as 2 points, female gender counts as a point, hypertension, vascular disease, which includes coronary artery disease with a previous heart attack or peripheral vascular disease, diabetes mellitus, congestive heart failure, previous stroke. All of those are risk factors in the CHADS-VASc risk score. And we really make decisions on how to approach patients based on what their CHADS-VASc score is. So the American College of Cardiology has made recommendations for first-line therapy being anticoagulation for patients who have a CHADS-VASc risk score of 2 or greater in men and 3 or greater in women. And of course, the higher the risk score, the greater the risk of stroke in those patients.
Having said that, it's not quite exactly like this, but, a CHADS-VASc score of 2, you can expect a risk of stroke of about 2%, CHADS-VASc score of 3, close to 3%, 5,
That's right.
close to 5%. So it all makes sense that
Yes.
we had. But there's the counterpart to that with the has-bled score. So obviously, you have to balance the risk of stroke versus the risk of bleeding when you're giving those anticoagulants. Is this something you use in practice also, Richard?
Yeah, absolutely. So the interesting thing, so the has-bled risk score also looks at different clinical factors that are associated with bleeding risk, because here we are giving blood thinning medications to patients, trying to prevent clots from forming in the heart and trying to reduce the risk of stroke. But when we do that, we increase the risk of bleeding in patients. So we always have to balance the risk of clotting versus the risk of bleeding. So the has-bled risk score is a risk score based on what clinical factors a patient has that increases their risk of bleeding. So it includes hypertension, renal disease, liver disease, previous stroke, previous major bleeding, an INR value, which is a reflection of the use of Coumadin, an INR value that's not been stable, meaning too high or too low, age over 65, medication use that increases the risk of bleeding, such as aspirin or Plavix or other non-steroidal anti-inflammatories, or high alcohol use. And the interesting thing about the HAS-BLED risk score is that it's not linear in the way that you were just describing with the CHADS VASc risk score. So for the lower risk scores, it's a 1-2%, but when you start getting up into the range of 4 or 5%, it starts jumping up to more of the 5-8% risk of major bleeding. So the higher the HAS-BLED risk score, the significantly higher risk of bleeding issues, and it becomes a really difficult situation in some patients because you notice that some of the things I just mentioned on the HAS-BLED risk score are also on the CHADS VASc risk score. So here it is, this double-edged sword. For example, I just mentioned
age and hypertension.
Yeah, exactly. Or previous stroke. So all three of those factors are on the CHADS VASc risk score, but they're also on the HAS-BLED risk score. So you feel like it's double trouble there, right? Yeah. You increase your risk of stroke, but you increase your risk of bleeding too. And the answer is yes, that's exactly true. Yeah. That's what's happening.
A lot of times there's a lot of discussion with the patient family. You have to individualize. And also in the HAS-BLED score, they don't talk about frailty or frequent falls. And I wouldn't be surprised to see some kind of a revision or incorporation of some other factors that we see so frequently in our patients. Right. So, obviously years ago, all we had was warfarin or Coumadin. And actually for patients with valvular heart disease, patients with IHSS, it's still recommended the treatment of choice, warfarin, particularly if you have, mitral stenosis or any type of valvular heart disease. But, in patients that don't have, valvular heart disease, then we have some options, don't we? We have some new direct anticoagulants. Can you tell us a little bit more about the choice that we have in anticoagulation?
Yeah, exactly. So it used to be that all we had was Coumadin. And the thing about Coumadin is that one's blood value has to be monitored. We call that INR, or international normalized ratio. And so an INR in most patients who are not taking Coumadin would be in the range of 1.0. For a patient who's on Coumadin and is taking the appropriate level, an appropriate INR would typically be 2 to 3. But the problem is that the level of Coumadin, or the dosage of Coumadin that has to be taken, is variable from one individual to the next. And it's also affected by vitamin K, which is in many green leafy vegetables, and it's also affected by other medications that a patient takes. So these levels are constantly changing based on what a patient is eating or what other medications they're taking, or just a number of different clinical factors. So it can be very frustrating because if the INR is too high, the bleeding risk is higher. If the INR is too low, then the clotting risk and the stroke risk increases. So there have been new medications that have been introduced. We refer to them as NOACs, novel oral anticoagulants. And the NOACs, at this point, we have 4 NOACs that are FDA approved for use in non-valvular atrial fibrillation. The beauty of these medications is that they can be taken based on a patient's kidney function, based on their age, based on their weight, and blood levels don't have to be checked. And in some of these trials, these medications were shown to be non-inferior to Coumadin, meaning they're just as good as Coumadin. And in one situation, or in several situations, they've actually been shown to be superior to Coumadin. In one particular case, a NOAC was shown to result in lower amounts of bleeding, lower amounts of stroke, and improved mortality compared to Coumadin.
Was that Pixaban, Richard?
That's exactly right. That was the Pixaban in the Aristotle trial. And often in the cardiology world, we typically get a trial that just gives us a benefit of one of those. So we either get a benefit of bleeding or we get a benefit of less stroke, not both. And so to get to this situation where these medications are giving us less bleeding and less stroke and less mortality, it is a huge benefit from both sides of the coin. And to patients, it's tremendous. So it's now part of the American College of Cardiology guidelines. It's a class 1 recommendation that if the patient has non-valvular atrial fibrillation, and if they can do it, if their insurance will pay for it, if they're able to afford it, if the clinical circumstances are appropriate, it is recommended that a NOAC be used instead of Coumadin, if at all possible. Yeah. And I have to say that this is a good time to talk about non-valvular atrial fibrillation, because these medications are FDA approved for non-valvular atrial fibrillation. What that means is that there are some patients, especially years ago, for whom they would have mitral stenosis, meaning the mitral valve doesn't open as well as it should open, and there ends up being calcification of the mitral valve. Those are primarily the patients who are considered to have valvular atrial fibrillation, or patients who've had a mechanical valve replacement. So those patients should be considered to have valvular atrial fibrillation, and they should be taking Coumadin. But if a patient has a little bit of leakiness to their mitral valve or one of their other valves, they should not be considered to have valvular atrial fibrillation. In other words, we could still consider using a NOAC in those patients rather than Coumadin.
Certainly, in some of the trials, there were some patients with prosthetic heart valve that were given one of the direct, thrombin or factor 10 inhibitor that actually did worse compared to Coumadin. But anyway, I mean, you look at Pixaban, for example, the Aristotle enrolled a huge amount of patients. There was over 20,000 patients. And their CHA2DS2-VASc score were not that high. And to show that kind of benefit, with decreased bleed, decreased stroke, and improved mortality is pretty phenomenal. As I remember the rivaroxaban trial, these had a higher CHA2DS2-VASc score or CHA2DS2 score, at that time. So it's quite impressive. Now, what about aspirin? What about in the patients that have a CHA2DS2-VASc score of 0 or 1? Well, let's say 1, for example. You give them aspirin at all? Do you think aspirin has any role?
So that's a great question. And it's something that we could discuss a lot. So the interesting thing is that the new guidelines for the American College of Cardiology have almost essentially eliminated aspirin from the guidelines. And the reason being is that the trial data for antiplatelet medications for atrial fibrillation is tremendously limited. So in the past, it's often been that there's a recommendation for patients who would have a CHA2DS2-VASc score of 0. Often there would be a recommendation for not taking anything or taking aspirin. And then for a patient who had a CHA2DS2-VASc score of 2 or higher, for them to take anticoagulation. But aspirin and other antiplatelet medications have really sort of disappeared from the new American College of Cardiology guidelines because we just have a lack of data supporting the fact that they actually work. Now, I think that this is one of those topics in which I think there can be a lot of disagreement on. I think there can be some controversy when it comes to those patients who have a CHA2DS2-VASc score of 1, because I'm just not sure that we really know. I think that there's a little bit of a lack of really good randomized controlled trial data, but we also certainly don't have good data to demonstrate that it actually does work in those patients. One thing that the American College of Cardiology guidelines do state is for patients who have that in-between phase, a CHA2DS2-VASc score of, say, 1 for men or 2 for women, that a clinician really has the ability to use their judgment and discuss it with those patients. So it's reasonable to use anticoagulation, such as apixaban, for that patient who has that in-between score based on what risk factors they have and also based on what the patient's preference is. So of the CHA2DS2-VASc risk scores, they're not all created equal, so to speak. The two weakest risk factors are gender and vascular disease, versus some of the other risk factors are greater in their predictive value for stroke. So, for example, maybe if someone has a risk score of 1 and that risk score for a man is vascular disease and they have none of the other risk factors, then maybe that's a weak predictor for that patient. But maybe that patient who has diabetes or some of the other, or congestive heart failure, for example, the risk factor in those patients would be a lot higher. And there are other limitations. For example, hyperthyroidism is not included in the CHA2DS2-VASc score. And those are a little bit of special circumstances. So I do think that clinicians have to remember the science of medicine, but also the art of medicine, and that is taking an individualized approach to the patient based on what their risk scores or based on what their risk factors are, not just the actual score itself.
Well, that's a very good point. So we have the warfarin, we have the new direct inhibitors, factors inhibitors, the NOAC, and then in the patients that cannot be anticoagulated at all, what about those atrial closure devices, such like the Watchman? I guess in the patients that have problem bleeding, patients that have repeated falls, and we're concerned about, subdural and intracranial bleed. Can you touch base a little bit? We probably should do a podcast just on that, but, about
Absolutely.
closure devices that we have,
Yeah, absolutely. So at this point, there is one device that is FDA approved, and that is the Watchman device. It is a device that's made by Boston Scientific, and there have been a number of clinical trials that have demonstrated non-inferiority of the Watchman device compared to anticoagulants. And this is something that is ongoing right now. So some of the initial trials compared the Watchman device just to Coumadin versus a lot of the newer data is starting to compare the Watchman device to some of the NOACs to see how it will fare in the future. So this is a very active and ongoing area of research. But it's a great opportunity for patients who cannot take anticoagulation in the long term. So say a patient who continues to have recurrent GI bleeds, or the patient who has had frequent falls and we're concerned about the risk of intracranial bleeding or orthopedic injuries, or, you can just, imagine the ongoing potential issues of why a patient may not be able to take blood thinning medication. And the other thing that's interesting, and we kind of talked about this earlier, the patients who have the highest CHA2DS2-VASc risk score are the patients who have the highest risk of stroke. But frequently, those are the patients who also have the highest risk of bleeding issues. So again, it really is double trouble for those patients. And so for the patients who get into that situation, this really provides an excellent opportunity. The Watchman device is a device that is delivered through a catheter that's placed in the vein in a patient's groin. It goes all the way through the vein up into the heart. We put it from the right atrium into the left atrium, and then it's delivered into a structure in the left atrium called the left atrial appendage. And the left atrial appendage is a little bit like a finger. It's a finger-like hollow projection from the left atrial appendage, from the left atrium. And it is where clots most often form in patients who have atrial fibrillation. So the best way to think about the Watchman device is it's a little bit like an umbrella, and the device is placed into the left atrial appendage almost like a an upside down umbrella when it's closed, and then the device can be deployed almost like opening of an umbrella, and it seals off the left atrial appendage. And when it does so, the heart will then eventually grow endothelium over the device, and endothelium is just kind of like skin on the inside of the heart. And once that happens, then there is functionally no more left atrial appendage from the left atrium. So clots can't form in the left atrial appendage, and they can't get loose, and they can't cause a stroke anymore. So it's a way to take the left atrial appendage out of the picture in those patients, and then blood thinning medication, anticoagulation is no longer needed. So it really is opening some tremendous opportunities for those patients.
Well, we have all this anticoagulation, we have the warfarin, we have the NOAC, and we have the atrial closure devices. Obviously, we try to prevent a stroke, but it never goes to zero. I mean, the best we can hope for is that we can bring the stroke rate to less than 1%. Isn't that true, Richard?
Absolutely. And so that's the thing about it. It's important to remember that any of the strategies that we use never reduce the stroke risk to zero. And so what we're doing is we are trying to reduce the risk of stroke. And unfortunately, we haven't figured out a way to eliminate it. But the reduction in risk of stroke in patients who are on appropriate anticoagulation therapy or in patients who've received a Watchman is a tremendous decrease in risk. And so it's important that as physicians, we explain to patients that the reduction in risk is tremendous. This is not just a slight risk reduction, because I've had a number of patients who were falsely under the impression that, if I take blood thinning medication, I still have a very high risk of stroke. And that's really not true. Does the patient still have a risk of stroke? Sure, but it's a very small risk in stroke versus if that patient is not taking blood thinning medication, the risk of stroke potentially is very high.
You probably bring them back to the risk of a normal population in certain circumstances. And you have some of these patients with risk of stroke per year that is in the order of 5 to 9%. You bring them down to 1% or less. That's very significant, So we talked about the stroke prevention. Number 2 is about rate control. Tell us how we do this, Richard, and why is it important?
Absolutely. So, it's interesting. You mentioned a triad. I almost consider it a dyad a little bit with a lot of my patients. And what I mean is I describe it as step 1 and step 2. So step 1, when I'm talking to patients, is the first thing we discuss. And that is we say, okay, there's this risk of stroke. How are we going to deal with it? What's our strategy? And I make a recommendation, and we have a discussion and come to an agreement about what the best thing is to do to reduce the risk of stroke. But then we go to step 2. And step 2 is deciding how to approach the patient's AFib. In other words, what is going to be our approach to the actual rhythm? Because reducing the risk of stroke with blood thinning medications or a device such as Watchman doesn't actually affect the atrial fibrillation. It just affects the risk of clot formation, which can cause a stroke. So patients need to understand that if they take a medication like a NOAC, that NOAC is not going to reduce the heart rate or keep them out of AFib, or it's not going to have any effect on the AFib itself. So step 2 is, how do we address their AFib? And there's 2 ways to approach it. And one is a rate control approach, and the other is a rhythm control approach. And so rate control is basically treatments that decrease the heart rate of the patient. And step 1 with doing rate control is typically using medications that slow the heart rate down, either through beta blockers or calcium channel blockers. And then there's a third option, which is using digoxin, but that is a less favorable option in most patients. But medications such as beta blockers and calcium channel blockers are the mainstay of controlling a patient's heart rate. But this is a very interesting scenario. So in the past, there have been studies that have suggested that rate control of atrial fibrillation in patients is just as good as a rhythm control approach. And of course, rhythm control is trying to get the patient into sinus rhythm if they're in AFib, or if the patient is already in sinus rhythm, it's using strategies to keep them from having episodes of atrial fibrillation. The challenge, though, is that clinical trials in the past have suggested that there's not a difference in stroke and there's not a difference in mortality between those two types of treatment. But that's a little bit of a simplistic way of looking at rate control. There are numerous trials and numerous studies that have suggested that patients who have a rate control approach to their atrial fibrillation will often have very bothersome symptoms. And those symptoms can lead to a decrease in their quality of life. So the decision between doing rate control and rhythm control for atrial fibrillation can be a very complicated decision that has to be based on a number of different clinical factors for the patient.
So, and the rate control is so important because we see several patients, a lot of patients in our clinic that have had congestive heart failure that was caused by atrial fibrillation that just was with rates that were so fast that it induced a cardiomyopathy. And I'm sure you see a lot of those as well, Richard, don't you?
Absolutely. And I'm so glad that you brought that up because that is just critical. So, there are situations that rate control can be appropriate. I tend to think that it is more appropriate in a patient who is very elderly or very frail, someone who maybe is not as good of a candidate for certain types of procedures that we might consider, such as ablation procedures that we'll talk about shortly, I'm sure. But if a patient has a rate control strategy, perhaps they're taking a medication like metoprolol or diltiazem, it is absolutely critical that we know that that patient has adequate rate control, that the heart rate is acceptable. And I think that means a resting heart rate of less than 85 beats per minute. But also, it's important to not just assess the patient in the office. It's really important that we assess the patient in everyday life through some sort of heart monitoring, whether it's a Holter monitor or a more extended cardiac event monitor. Because the problem is there are a number of patients who, when they're sitting still in a physician's office, they can have a heart rate that appears acceptable. The problem is when the patient gets up and walks down the hall, sometimes their heart rate will immediately jump up to 120 beats per minute, just walking down the hall. And that's not physiologic. That the heart rate should go from 80 to 90, perhaps, if they're walking down the hall, not 80 to 120 or 130. And the way I describe it to patients is I say, when you get in your car, you can step on the gas pedal and perhaps rev up your engine to 6,000 RPMs or whatever for a brief period of time, in the process of acceleration. But if you keep your foot on the pedal and you leave the RPMs really, really high, then soon enough your engine's going to blow up, and you're going to hurt your engine in your car in one way. So can your heart go fast for a period of time and not be damaged? Sure, of course. We do it all the time. It's called exercise. But we exercise for 30 minutes or an hour or whatever, and then we take a break. But a patient who has atrial fibrillation and an elevated heart rate, it's almost like they're exercising 24 hours a day, 7 days a week in terms of what their heart's doing. And after a while, the heart just starts to wear out. And that can lead to cardiomyopathy, which can typically be the same thing as congestive heart failure. And that's something that's treatable and reversible if it's caught soon enough. But it's important that it be treated and then it be treated quickly, because otherwise over a period of months or longer, it can turn into a cardiomyopathy that is not treatable and cannot be reversed.
It's very important and so important to specify the fact that it is reversible. And we've seen so many patients that normalize their heart function after we control their rate or that we bring them back to a normal sinus rhythm. Well, thank you very much, Dr. Vest. I mean, this was really important information, and I think the points to take home is, number one, our priority is stroke prevention, and we can do that with all the anticoagulation, medicine that we have, and also the rate control, which is so important to prevent congestive heart failure because the risk is so high in these patients with atrial fibrillation. Next podcast, we'll talk about rhythm control and whether it could be important in some patients to bring the heart rhythm to a completely normal sinus rhythm. Thank you very much for your collaboration, Richard, and we'll talk to you next time.
Thank you so much. I'm looking forward to it.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.